So good morning, everyone. So I'll be speaking on the echocardiographic findings in rheumatic heart disease, as well as the preventive aspect of rheumatic heart disease. So, rheumatic heart disease continues unabated among middle and low-income countries, and in some of the indigenous communities, even in the developed world. At least 15 million people are estimated to be affected by rheumatic heart disease worldwide. And although there are criteria for acute rheumatic fever, which we all know is the Jones criteria, however, there are no such widely accepted criteria for rheumatic heart disease. So, secondary prophylaxis still remains the only cost-effective approach as far as control of rheumatic fever progressing onto rheumatic heart disease is concerned. And this is especially useful for patients who are in the mild asymptomatic category of rheumatic heart disease, because in the absence of acute rheumatic fever recurrences, the majority of these patients will have no detectable disease within the next 5 to 10 years. Screening to detect asymptomatic cases therefore remains a very attractive strategy, as we'll see later on in this next few slides, how patients of rheumatic heart disease, up to almost nearly 40 to 50% of them, will never give a history of acute rheumatic fever in the past. And that's the reason why echocardiography has now proven to be more sensitive and specific compared to auscultation. So what is the role in the current era of echocardiography in acute rheumatic fever? First and foremost, it affirms the dominant role of valvular pathology rather than the myocardial disease in the clinical manifestations of rheumatic heart disease. It confirms the clinical findings and allows assessment of, first, severity of the valve involvement. So whether for example, if there is mitral regurgitation, so what is the severity of regurgitation? Next, we can also look at the chamber sizes as well as the ventricular function. And last, presence and size of pericardial effusion, if present, can be detected easily by 2D echocardiography. It also helps in serial assessment of the disease progression. So in case the patient keeps getting recurrences of rheumatic fever, then we can have a serial monitoring of the worsening of valve pathology. It may also help in exclusion of valve involvement in cases which are suspected to be rheumatic fever. So it can be a very handy tool in such cases. Also, it helps in earlier detection of carditis in cases of acute rheumatic fever. And in some cases, it helps in detecting what is called a silent or subclinical carditis, which I'll come to it later. So based on this newer evidences of the role of echocardiography in detecting asymptomatic cases, the Jones criteria was revised by the American Heart Association in its scientific statement published in 2015, where you can see that now clinical or subclinical carditis has been added to the criteria as a major criteria. So it's especially useful in the moderate and high risk populations, and we'll come to it again in the next few slides. So what are the echocardiographic features of rheumatic carditis? We all know that rheumatic carditis is span-carditis, in the sense it involves all three layers of the heart. Pericarditis and myocardial involvement in the form of congestive cardiac failure is almost rare in the absence of significant valvular involvement. It is said that all cases of congestive cardiac failure are because of severe valve regurgitations and not because of myocardial dysfunction. So valvular involvement is critical to the diagnosis of rheumatic carditis. If there is no valve involvement, it virtually rules out rheumatic etiology. In most cases, the valve involvement may not be severe enough to be symptomatic, as we mentioned earlier, so that you may not get clinically auscultable findings in patients with mild valvular involvement, and that's the reason why echo becomes handy in these cases. Presence of valve regurgitation detected by echo or Doppler only without the clinical evidence of carditis is termed as silent or subclinical carditis. And then up to 50% of chronic rheumatic heart disease patients never give a history of rheumatic fever. So in fact, there was a trial from New Zealand which showed that echocardiography alone diagnosed regurgitation lesions became audible within the next 2 weeks of diagnosis. Mitral valve, we all know, is the commonest valve involved in acute rheumatic fever. In acute rheumatic fever with carditis, involvement is to the tune of 94%, and in cases of recurrences, it's as high as 84%. Diffuse thickening of the mitral valve is universal in recurrences, but it is seen in only 40% of cases in the first attack of acute rheumatic fever. So there could be focal nodular thickening of the body and the tips of the leaflets. Nodules, which are around 3 to 5 millimeters in size, they have different echogenicity from the valve structures and do not have the characteristic mobility of endocarditic vegetations. So you can see in this picture, which I have put on the right side of this slide, some of these nodules along the margins of the valve leaflets. They have a different echogenicity compared to the normal valve, and which is the reason why they can be easily detected on a 2D echo. Valve prolapse is present in only about 8.6% of cases in the first attack and increases to around 13% in the second attack. Majority of the regurgitant lesions of the mitral valve, that is nearly 70%, they are directed posteriorly. So there is prolapse of the tips of the anterior mitral leaflet. So there is loss of coaptation at the tip between the AML and the posterior mitral leaflet. However, there is no billowing of the medial portion, which is a major differentiating point to separate acute rheumatic fever related mitral regurgitation vis-a-vis mitral regurgitation of mitral valve prolapse. The next reason for mitral regurgitation could be annular dilatation, which is common in recurrences as compared to the first attack. There could be also elongation of the chordae of the anterior mitral leaflet, which could result in mitral regurgitation. And very rarely in severe cases, there could be rupture of the chordae tendineae, resulting in severe mitral regurgitation. Next is the aortic valve involvement, which was detected in 39% of patients with acute rheumatic carditis as per one study. And in 17% of these patients, only echocardiography showed evidence of aortic regurgitation. That means it was clinically not detectable. Most of the times, aortic regurgitation is not physiological in children, what we mention as physiological AR or a normal AR. And that's the reason that all aortic regurgitation which are detected by echocardiogram in cases suspected to have rheumatic carditis should be considered as an evidence of abnormality and not as a physiological AR. The mechanism of aortic regurgitation could be many. These include leaflet thickening with deficient coaptation. There could be prolapse of the leaflets resulting in aortic regurgitation. There could be annular dilatation, again more commonly seen in recurrences rather than the first attack of acute rheumatic fever. And in chronic cases, there could be aortic leaflet retractions resulting in aortic regurgitation. The other two remaining valves, that is tricuspid and pulmonary, so usually isolated involvement of these valves is virtually unknown in rheumatic carditis. There could be left ventricular dilatation also on echocardiography, again seen commonly with recurrent carditis. And if it is present in the first attack itself, it is usually secondary to moderate to severe regurgitation lesions of the mitral and or aortic valve rather than a left ventricular dysfunction. Pericarditis is unusual without there being underlying severe valve involvement. So in isolation, pericarditis is almost virtually never seen. So apart from this diagnostic role, there is a prognostic role of echocardiography as well in patients with acute rheumatic fever. As per one study which was published in 1992 in the British Heart Journal, 4 out of the 6 patients with Doppler valve involvement, they continued to have it even up to 18 to 36 months later on. And if echo did not show carditis, then these patients did not develop regurgitation on follow-up. Now coming to the findings in established rheumatic heart disease. So the first and foremost is the mitral valve, which is most commonly involved. We've already seen what are the acute changes in the mitral valve present in acute rheumatic fever. In chronic stages, these could involve leaflet thickening, There could be caudal thickening and fusion leading to restricted leaflet motion, and there could be, in severe chronic cases, even calcification of the mitral valve. So as you can see in the pictures which are on the right side of the slide, so this is a parasternal, the upper one is a parasternal long axis view, which is a classical view we see in rheumatic heart disease involving the mitral valve, where there is a hockey stick depiction of the anterior mitral leaflet. The posterior mitral leaflet is immobile. Both the valve leaflets are thick. There is fusion of the chordae tendineae as well. And in the short axis, you can even see the typical fish mouth appearance because of incomplete opening of the valve leaflets. In the upper slide, you also see there is presence of pericardial effusion. Again, another set of pictures of 2D echo. The figure A showing the typical hockey stick appearance, thick and little bit calcified posterior mitral leaflet which appears to be stuck. Fish mouth appearance in figure D. In figure C, you note that this is a M mode taken at the level of the tips of the valve leaflets, and the arrows depicting that there is the restricted mobility of the posterior mitral leaflet. So ideally during diastole there should be separation of the anterior and the posterior mitral leaflet. That is, they should be moving away from each other, but you can see that the posterior mitral leaflet tends to remain in the same position. And in figure E you can see the similar on a 3D echocardiography. Aortic valve leaflets could also develop changes during chronic rheumatic heart disease, and these include irregular or focal leaflet thickening. There could be loss of coaptation, there is restricted leaflet motion, and also there could be presence of leaflet prolapse. So in this picture you can see a thick aortic valve, especially the margins, which have nodular there is a nodular picture of these aortic valve leaflets along the margins, and there is loss of coaptation. As you can see, there is presence of central opening which results in aortic regurgitation. Now, as we mentioned earlier, because of the presence of rheumatic heart disease without there being a history of rheumatic fever, there could be many cases who would go undetected, and that's why the role of diagnosing rheumatic heart disease in asymptomatic population, so that we prevent them from progressing to severe cases. That's the reason the World Heart Federation in 2012, they came out with the criteria to detect rheumatic heart disease in asymptomatic population. So based on these, they have devised these criteria. So there are echocardiographic criteria for individuals who are less than 20 years, based on which they can be detected as either having definite rheumatic heart disease, or they could be having borderline rheumatic heart disease, or they can be labeled as normal. So what does definite rheumatic heart disease mean? So they could have any of the 4 criteria. So which could be, first is pathological mitral regurgitation, along with at least 2 morphological features of rheumatic heart disease of the mitral valve, which I'll explain in the next slide. What are the morphological features? B is presence of stenosis of the mitral valve with a mean gradient of more than or equal to 4 millimeters of mercury. Or they could have a pathological aortic regurgitation along with 2 morphological features of rheumatic heart disease of the aortic valve. Or D, they could have borderline disease of both aortic and mitral valve. And borderline rheumatic heart disease, the criteria include there should be at least 2 morphological features of rheumatic heart disease of the mitral valve without there being a pathological regurgitation or stenosis. Or criteria B is there could be just a simple pathological mitral regurgitation without the morphological criteria, or a pathological aortic regurgitation without the morphological criteria. And when can a patient be reported as normal? It would mean that there is mitral regurgitation that does not meet all the 4 Doppler echocardiographic criteria to be labeled as pathological mitral regurgitation. In other words, also labeled as just a physiological MR. Similarly, for aortic regurgitation, 4 criteria which are not met by Doppler should be labeled as physiological AR. Or there could be an isolated morphological feature of the rheumatic heart disease of the mitral valve, for example, valvular thickening, but without any associated pathological stenosis or regurgitation. So you could have a person with a myxomatous mitral valve, where the valve may appear a little thick, but there may be no associated stenosis or regurgitation. So such patients should not be labeled as having rheumatic heart disease. And lastly, morphological feature of rheumatic heart disease of the aortic valve. Similarly, for example, valvular thickening, but again without any stenosis or regurgitation. So now, what are the criteria to label a regurgitation as being pathological? So as far as mitral regurgitation is concerned, it should fulfill all the following 4 Doppler echocardiographic criteria. That is, that the mitral regurgitation should be seen in at least 2 views. The jet of the mitral regurgitation in at least one of the views should be more than or equal to 2 centimeters in length. The velocity of the mitral regurgitation should be more than or equal to 3 meters per second for one entire complete envelope of the mitral regurgitation, and the envelope should show a pan-systolic jet. So for example, in this picture on the right upper side, the upper figure shows the continuous wave Doppler of the mitral regurgitation jet, where you can see that the jet is pan-systolic. It has a nice complete envelope. The velocity is more than, in fact, 5 meters per second. Similarly, for aortic regurgitation to be labeled as pathological, it has to fulfill the following 4 Doppler criteria. Again, it should be seen in 2 views. In at least one of the views, the jet length should be more than or equal to 1 centimeter. Velocity should be more than 3 meters per second in the early diastole, and the jet envelope should show a pan diastolic jet. So this figure on the right lower side depicts the same features. There is a pan diastolic jet, and the velocity, as you can see, is nearly almost 6 meters per second in the early diastole. So this is how we can label a mitral or aortic regurgitation as being pathological and not physiological. So for this, all the 4 criteria have to be met. If they are not, then we cannot label them as pathological. Coming to what are the morphological features of rheumatic heart disease. So features of the mitral valve by which we can label them as being morphological features include thickening of the anterior mitral leaflet being more than 3 millimeters. So now this applies to patients who are less than 20 years of age. There should be presence of caudal thickening. The leaflet motion has to be restricted, and there is excessive leaflet tip motion during systole. So as we noted, the leaflet tip motion tends to remain mobile compared to the middle as well as the base of the valve leaflets, which are more restricted in opening. Similarly, features of the aortic valve include irregular or focal thickening of the valve leaflets. There is presence of coaptation defect. Most leaflet motions are restricted, and there could be presence of prolapse. So if 2 or more criteria of the morphological features are fulfilled along with the presence of pathological regurgitation, then these cases could be labeled as being definite rheumatic heart disease. So cases which are categorized as being definite rheumatic heart disease, of course they need to be on secondary prophylaxis. Those fitting into borderline rheumatic heart disease, so which we saw here, the borderline rheumatic heart disease, the house is divided whether in these cases we need to give them rheumatic heart disease prophylaxis or not. It would depend from person to person, from place to place, from center to center. Now coming to the prophylactic aspect of rheumatic fever and rheumatic heart disease. So what is primary prophylaxis for rheumatic fever? It essentially means adequate antibiotic therapy of group A streptococcal upper respiratory tract infections so as to prevent it from progressing to an initial attack of acute rheumatic fever. As compared to secondary prophylaxis, which is continuous, this is intermittent. As we all know, group A streptococcal infections, they are endemic throughout the world. And sporadic epidemics are known to occur in schools, in facilities for elderly, as well as in military personnel. And group A streptococcal infections, they are common in children between the age group of 5 to 15 years of age. However, only 20% of pharyngitis are secondary to group A streptococcal infections, the majority being secondary to viral infections. So that's the reason we cannot go around and give primary prophylaxis to all cases of pharyngitis. However, there are some factors which can improve the accuracy of diagnosing somebody as having a group A streptococcal infections. These include age less than 15 years, history of having high grade fever, presence of tonsillar swelling and exudates, presence of tender anterior cervical lymphadenopathy, and the absence of cough. It was seen that if 4 out of these 5 criteria were met, there was nearly 50% chance that the case could be having a group A streptococcal infection. However, the sensitivity or the odds ratio dropped as the number of criteria also dropped. And this is a chart depicting the signs and symptoms as compared to the age groups for group A streptococcal infections. So infants, as we can see here, usually don't have tonsillar pharyngeal or pharyngeal exudates, and they also tend to have coryza and excoriated nares as compared to older children and school-going children. School-age children as well as adolescents, they tend to have the typical symptoms of anterior tender cervical lymph nodes. There could be a rash, which is uncommon as compared to infants, which is uncommon in infants and common in school-age children and older children, and presence of tonsillar or pharyngeal exudates. Apart from this, there could be lab investigations which will help in diagnosing somebody as having a group A streptococcal infections. So we have the throat swab culture, which is usually collected by vigorously swabbing the tonsillar crypts as well as the posterior pharyngeal wall, and the culture is usually carried out on the blood agar and may take 24 to 48 hours to show the presence of growth. Then there could be rapid antigen detection tests which can help in diagnosing group A streptococcal infections. It is important to remember that primary prophylaxis has to be given within the first 9 days of onset of symptoms so that an acute episode of rheumatic fever could be prevented. Penicillin remains a drug of choice. Tetracycline and sulfa drugs are contraindicated in acute rheumatic fever. So these are the various drugs which are available for as primary prophylaxis. Benzathine penicillin, a single intramuscular injection. We all know 1.2 million units for children more than 27 kilos and 0.6 million units for children who are weighing less than 27 kilos. You could also give them oral penicillin V, which is given for a period of 10 days. You could also give them oral amoxicillin, especially in those who cannot tolerate oral penicillin. You could very well give them amoxicillin for a period of 10 days. First generation cephalosporins also can be used, and patients who are sensitive or allergic to penicillin, they can be treated with erythromycin for a period of 10 days. If a patient develops recurrence of pharyngitis, it is very essential that we do a throat culture. Even typing of the M polysaccharide antigen may be necessary so as to differentiate whether this recurrence is because of treatment failure or is it a new onset infection. If the infection is a new onset, then the same antibiotic can be repeated. However, if it's a recurrence and initially oral penicillin was given, then it's recommended that we give a single intramuscular dose of benzathine penicillin. Those patients who are, or those infections rather, who diagnosed to have penicillinase producers type of organism, they can be treated with clindamycin or amoxicillin clavulanate combination. Coming to secondary prophylaxis, which we mentioned earlier, that it's a continuous administration of specific antibiotics to patients who have already had a previous attack of rheumatic fever or are diagnosed to have well-documented rheumatic heart disease. The purpose of the secondary prophylaxis is to prevent colonization as well as infection of the upper respiratory tract with group A streptococcal infection and prevent the development of recurrent attacks of rheumatic fever so as to prevent the progression of valve-related issues. The antibiotics which are used in secondary prophylaxis include again benzathine penicillin, a single intramuscular injection which can be given every 3 to 4 weeks. In usually high endemic zones, especially in our country, we tend to give it every 3 weeks or every 21 days. Oral penicillin 250 mg twice a day could also be used. Sulfa drugs, which are rather contraindicated in primary prophylaxis, can very well be used as a secondary prophylaxis of rheumatic fever. And again, erythromycin for patients who are allergic to penicillin or sulfonamides. As per one study, the compliance rate with benzodiazepine penicillin was noted to be between 40 to 86%. And the recurrence rate also varies depending on the type of prophylaxis used. It's very low, that's 0.4% in those who are on intramuscular penicillin, compared to nearly 5.5% on those who are on oral penicillin V, and 2.8% in those who are on oral sulfadiazine. Coming to the next question as to how long do we continue secondary prophylaxis. In those patients without a proven carditis, so the duration of prophylaxis, you could give it for 5 years after the last attack or until 18 years of age, whichever is longer. In those patients with carditis, which include mild mitral regurgitation or a healed carditis, you could give it for 10 years after the documented last attack or at least until 25 years of age, whichever is longer. Now these duration vary from region to region. So for example, the Australia and New Zealand guidelines, they mention for patients without proven carditis to be given for 5 years or until 21 years of age, and similarly for patients with carditis again for 21 years of age or for 10 years after the last attack. For patients who have severe valvular disease, prophylaxis should be ideally lifelong, and again it would remain lifelong for patients even after valve surgeries. So coming to the last slide, what are the points to remember from this? Essentially to remember that the Jones criteria has been revised. So echocardiography is now an important aspect of the Jones criteria to detect subclinical carditis, which has become now a major criteria. Congestive cardiac failure in acute rheumatic fever is secondary to valve involvement and not because of myocardial dysfunction. It is important to detect cases with rheumatic heart disease without there being a preceding history of acute rheumatic fever, so that these patients can be put on secondary prophylaxis and prevent them from getting into a severe category. Thank you very much.